Lovely. Thank you. Good morning, everybody. Welcome to the NHFT Council of Governors meeting in public. My name is Julia Curtis. I'm one of the non-executive directors and deputy chair of NHFT, and Krishni Waring, our trust chair, is on leave this week, so I'll be guiding us through. So welcome to two new governors. Councillor Brian Bennyworth, you're very welcome, from Northamptonshire, and Councillor Laura Coos from West Northamptonshire Council as our partner governors. So you're very welcome to your first meeting, and look forward to working with you going forward. Welcome to Faisal Hussain, who's our interim chair, starting in November, and he's observing the council as part of his handover from Krishni. We have some governor apologies. We have Rupal Shah, and we have some executive apologies from Angela Hillary, our chief executive, and I know David Mayer's here in representing Angela, and from Anne Rackham, our chief operating officer. Just Tracy and Joe, if there's any last minute apologies that we haven't noted, the others we need.
I know Mark Major's an apology for today as well.
We've also received from Dion Mayhew, who's the People Director.
Lovely, thanks very much. Okay, we'll note those, and we'll move on to declarations of interest. So we have a paper A, which is the summary of all our declarations of interests from governors. Any comments from anybody, anything anybody needs to add at this point for anything on the agenda? No, and just a reminder that any changes to the declarations just need to be submitted through our Foundation Trust email inbox. Great, thank you. And thank you, Tracy, who've noted another apology in the chat. Thanks very much. Okay, so we'll move on to paper B, which is the minutes of our previous Council of Governors in public from the 5th of June. Any matters of accuracy at all? Great set of minutes, thank you. Anything from anybody? I think there's no open actions on the action log, so whether there's any other matters arising from those minutes, anybody got anything they needed to add? No, great, thanks very much. In which case we'll move on to our governor section, governor matters, and we're going to very, very pleased that Monica, one of our partner public governors for Kettering and Corby, has agreed to come and talk to us a little bit about herself. Welcome, Monica, great to see you again. I'm going to let you introduce yourself. So for people who are new, this is a section where we ask governors to do a little short introduction to themselves, just so we can get to know people a little bit better. And we have the opportunity of asking a few questions and just understanding the context of new people, our governors and their roles. So I'm going to hand over to you, Monica, if that's okay, and let you lead us through. Thanks very much.
Thank you. Good morning, everybody. Can you hear me all right?
Yeah,
Can everyone hear me? Yes.
Yeah.
Yes. Okay, good. Okay. So my name is Monica. I'm public governor for Corby and Kettering. I picked the short straw, and I will try and talk you through how I've ended up here as public governor. So Tracy will help me out with my slide. So my background is originally I'm from Zimbabwe, and I relocated to the UK, to England, 2003. I've used pictures for my presentation just to try and put visualization. So I grew up in Zimbabwe. My father was a policeman in what was Rhodesia. We were a British colony, and he became a human resources director for Fidelity Life Insurance, which was one of the largest insurance firms in Zimbabwe. Now, my background is starts off at 8 years old. My parents' marriage broke down, and I found myself living in rural Zimbabwe, which is the pictures. This is where I grew up between the ages of 8 and 12. My father just took me there and left me there for 4 years of my formative life. And the only memory I have of that massive change was him telling me I needed to be able to survive in any environment. I think social services would have had plenty to say about that, but that was my life for 4 years, and that is important because that has shaped me for who I am and what I am today. In 2000, Zimbabwe President Robert Mugabe, some of you might know him, there was an economic fallout with Britain at the time, and the economy took a downward spiral. We had probably one of the highest rates of inflation. We had that note in the picture is a $100 trillion note that was being used for trading in the country at the time. I was newly qualified, newly married with a baby, and we had sanctions. Tony Blair put sanctions on our country, and we could not, I could not buy baby formula, and I remember making that decision that it was time to leave the country. So I found myself in London at one of the largest NHS hospitals as a newly qualified radiographer with a baby working in London. So that's how, in an essence, my story is not unique. That's probably resonates with a lot of NHS health workers, how we find ourselves here. And moving on to the next slide, please. My passion for what I do is it resonates around my children. I am a strong advocate for speaking up. In the pictures, you will see my sons. My oldest is 24, my youngest is 12. And as a parent, as a Black and ethnic minority parent, I find myself having conversation with my children around speaking up, which often translates into the work environment in our institutions about speaking up and calling out racism. My son had to experience that at 6 years old in a playground, being called names and things like brown poo and things like that. So as a parent, it's conversations that I have to have with my children. It's conversation that I have to have in the work environment about speaking up and trying to eradicate racial discrimination. And so I teach my children about speaking up, and which I apply, like I said, in the work environment as well. So that's one of the things that I'm quite passionate about, speaking up. Next slide, please, Tracy. Thank you. And I am a strong advocate about building bridges and breaking down walls, because I think that it is important that we find a balance in our differences, in our diversity. I find myself in places where sometimes I am the only Black and ethnic person in the room, and I run my own business, and I have a diverse team of staff. And equally on the other side, I have a diverse business partners that I work with. And often I find myself in environments that are quite uncomfortable, but I do take it in my own stride. There's a picture of me with Steve Patman, the Kinky Boots showman. He came to an event that we were doing for Women's Institute, of which I'm a member of Great Oakley in Corby Women's Institute. So that's me with him, which was completely out of my comfort zone, but I do embrace in my own stride, because I feel it is important as a community that we are able to build those bridges and integrate within our communities. Next slide, please. AC. Other things that I do, I'm a strong believer in partnership and collaborative working, because ultimately we all need each other as organizations. We need our staff groups, and equally our communities need the services that we provide. And I am a strong believer that we need to find a way of collaboratively working together in order to deliver the services that is required. And as a business person, we need clients, and there is so much to be achieved by working together. collaboratively. Thank you, Tracy. Next slide, please. Relevant work experience of over 20 years in the clinical environment. I've worked for the NHS 11 years, then I went into the private sector for another 9 years. Other things that I do in the community, I'm a public health advocate for Black and ethnic minority groups to try and address some of the inequalities with health issues. We have high rates of simple things like diabetes, blood pressure, non-attendance for hospital appointments. So I often get invited to talk about the reasons for medical tests and examinations, to try and be a trusted voice within the community. So I do go out and try and integrate within our communities for health and well-being, for the services that are available, again, to bring awareness of what is out there, that our communities can access as required. Thank you, Tracy. Next slide, please. And other things that I do, I am a chaplain at Kettering General Hospital. I pivoted slightly away from my original job role as a radiographer, and I retrained and became a hospital chaplain. So I do that at Kettering General Hospital. Again, to try and build bridges between religious groups, which is also important in our community, especially for the Black and ethnic groups. Religion is quite a strong fundamental aspect, and so I often find myself having to advocate for the balance between religion and health services as well. Thanks, Tracy. Next slide, please. Again, another thing that is I'm passionate about is being a role model for the community, that we have to be inclusive in our behaviors and challenge any bias and discrimination. And I often go into rooms where I'm the only one and I'm comfortable with that. So it's just trying to demonstrate that there is a way of working together for common goals. Thanks, Tracy. Next slide, please. My personal drive is my children, like I mentioned earlier. For me, I am passionate about demonstrating to them that the world is available to them. When my daughter was when she was 1, I was involved in a car accident, near fatal car accident. I barely survived and needed 8 operations. I had an extensive head injury, which you can see in the pictures. My hair doesn't grow. People don't often realize. But for me, raising a child in England children in the UK has come with its own challenges. Like I mentioned earlier on, they have to navigate racial biases in the school systems. And for me, being able to be a role model for my children is a personal drive for me. For my daughter, I've had to navigate mental health in the education system, what support is available to our children, and where can they go for support. So that translates even in our working environment, the accessibility and the availability of mental health support to our staff and to our patients as well. Thanks, Tracy. Next slide, please. As a governor, I would like to believe I bring a balanced life experience. I've been an employee, and now I'm an employer. I've got a lot of years in the clinical environment. A hospital chaplain allows me to bring in a spiritual aspect to how we support our staff and our patients. I bring in experience. I'm a bereavement therapist, which has a mental health support element in it. I also am a menopause health and wellness coach within the Black and ethnic groups. Public health collaborative ambassador. Ignore the last, that was just a tongue in cheek there. I don't want to be prime minister. I think my husband couldn't cope with that. Thanks, Tracy. Next slide, please. My pledges as a governor is I would like to contribute in tackling racial bias and promote more a more inclusive society that is quite close to my heart, and more importantly, to celebrate our diversity within our staff groups, our patient groups, and make sure everybody feels valued and respected. To foster a supportive and anti-racist environment within our workplaces, and to advocate for public health approach to end some of the disparities that we find amongst our ethnic groups. And the last slide, please, Tracy. My approach is to try and build bridges and get rid of the walls, the invisible walls within our community groups, so that there is always open dialogue, and to reach out across our differences to try and find shared values and shared goals and work towards mutual understanding. And also to try and move away from the isolation and separation and tackle some of the issues that our patient groups and our staff groups experience, where there are boundaries and barriers of us versus them. And so those are some of the roles that I'm passionate to try and help bridge the gaps in an essence. I think that's about it in a nutshell. I had to talk too fast. I'm looking at the clock. Thank you very much, Tracy.
Thank you so much, Monica. Wow. Just thank you, firstly, for being so open and sharing some of the challenges that you've faced yourself and your family. You know, we really appreciate the open and honest approach you've taken to that. Very inspiring. Thank you. I know people want to comment or perhaps ask a few questions, but I'll just give you a minute to breathe, and I'll invite people in for comments and questions.
That's fine. I'm ready.
Thank you. Thank you. Mabel, I can see your hand is up first. Thank you. Mabel, we can't hear you. I think you're just on mute.
Yeah.
Great.
Is that better?
Yeah.
Thank you. Thank you very much for that. I loved that. I really enjoyed it. I was really pleased that you're looking at health and well-being. If you want any information on diabetes, you're very welcome, because I'm a trustee of the Independent Diabetes Trust, which is in Northamptonshire, and we have got a wealth of nice leaflets and really good information. If you want to contact me, you're very welcome to.
Thank you,
leaflets
Mabel.
and all the rest of it. Thank you.
Thank you.
Lovely. Thanks very much, Mabel. Itai, please.
Hi, Monica. I just want to thank you really for being really brave and sharing some quite deep and personal things about yourself. It's quite inspirational to see, you know, how you've overcome some major life events. Yeah, and possibly you bring that to your bereavement counseling in terms of, you know, that skill and resilience, and it's quite a yeah, it's quite an inspiring story. So thank you so much for sharing.
Thank you.
Thanks, Itai. And actually, Monica, if you have a look in the chat, there's a whole stream of people saying thank you for sharing. You know, your incredible strength and determination comes through. Inspiring story, inspirational, and a really wonderful presentation. So I think that tells you that we've really appreciated that. Michael, did you want to come in?
Oh, yeah, thanks. Monica, thank you so much. You know, I know everybody has said what an inspiration, and it's not meant to be a cliche, but honestly, you are incredible. So thank you.
Thank you.
I guess what I wanted to ask you in terms of your work with the communities, is there very much still an intergenerational issue in terms of some of the barriers that you've reflected on, and what do you think some of the key messages are that we can take? I'm just, you know, thinking about us as a diverse group of governors as well. I'm just really interested to learn, you know, from your experience, what some of the intergenerational boundaries are, and some of the things we should be thinking about.
I think we're now in situations where we now have the original migrants, if I can call us that. So the parent groups that relocated, and then we're now into a season where we're now having the children born or raised in the UK, and the aspects, the challenges are a little bit different, especially into our younger into the younger age groups of our young people. Some of the resilience is different to the parents, to the general. There are things that I could not picture my children to be able to endure. I guess my encouragement would be to find there's always a trust element. There is a trust element that always comes into play with these things. There was in one of my slides, I did mention that there is a them versus us element that goes even amongst our staff groups. So as an organization, I think I don't know how we can tackle it, where we have to find or identify trust voices, people who can really advocate for the health issues and the resources available, that there are no conspiracies. This is to help you, and this is what you know, how we need to work with the organizations as a people group. Yes.
Thank you. Thank you. Thanks for the question, Michael. Laura, did you want to come in?
I did indeed. Thank you so much for letting me speak. Monica, I can feel how emotional this is for you. It's absolutely amazing and so brave of you. I just have to say, I was also born and bred in Zimbabwe, and it's such a pleasure to sort of like say hello across the cyberspace and fully understand your story. It's tough. It's a really, really tough one, and it's just incredible how far you've come and how much farther you can go and teach your children that. It's amazing. Thank you.
Thank you.
Thank you very much, Laura. Thank you. Just see if there's anybody else wanted to come in. I think that might be it. Duncan, did you want to come in?
Yeah, I was just going to add, Monica, my thanks. In a previous career, I was an executive director at an acute trust, which had really deep-rooted problems with racism. And I became a firm believer that it was only through the bravery of people like yourself speaking out, that you got an understanding throughout the organisation of the challenges that continue to be faced, not least of all by your children, as you so clearly explained to us. my insights to much of this became so much deeper through personal stories told and shared through reciprocal mentorship. And I think, you know, you should be absolutely applauded. It's very brave to turn around and tell people about yourself, but it is also the way to help people understand what is going on. So thank you.
Thank you.
Thanks, Duncan. Thank you. Really important point there. And again, Monica, there's lots of people commenting in the chat. I'll let you read those at your leisure during the meeting. A couple of things from me. One thing I've heard quite loudly from you this morning is about the importance of advocacy. And we certainly, you and I attended that event for internationally educated nurses a short while ago, and heard some very interesting stories of people's challenges when they came from different countries over here to the UK to be part of the health service. And that really made me think about you know, attitudes and, you know, being much more open, but certainly being advocates for people. And I think if we can help all of our staff become advocates for each other, and particularly for our communities, you know, we're doing a good job if we can get to that point. So thank you very much. And the last point I was going to make is actually, you are absolutely inspirational, truly. But I think collectively as a group of governors, everybody brings something slightly different. And I think by sharing stories, it's a, you know, I've been so honoured over the last few years to listen to people's stories, because then it brings us so that we're all aware of the richness of people's contributions. And so thank you. You've contributed to that hugely this morning. So on behalf of everybody, thank you for being brave and standing up and being so open. So thank you very much for that.
Thank you so much.
Follow that.
Thank you.
Is what I say. Thanks very much. I'm afraid, Richard, you're going to have to follow that. So we move on to the Council of Governors report, paper C, which Richard Smith, our Director of Corporate Governance, is going to lead on. So thank you, Richard.
Thanks, Julia. Yes, indeed, Monica, you set rather a high bar. I suspect my presentation of sorts is perhaps paling in comparison. So thank you very much from my point of view for sharing your story. Turning then to the Council of Governors report, which is really more a reflection of the work that's going on right across the council rather than my work. There are probably four key areas to cover in this month's report. But before we get into those four areas of work that have been happening across the council, I'll just add my welcome to our two new partner governors, Councillors Bennyworth and Coos, who've joined us for the first time today. You are indeed very welcome on our Council of Governors. So stepping through then the report, which Julia mentioned, is paper C in the pack. I'll turn first to a recent workshop that we held in a long-running series of workshops, actually, between NHFT's Council of Governors and the Council of Governors for Kettering General Hospital NHS Foundation Trust, or KGH. On this occasion, given the recent announcements of the government in a change of direction for the NHS nationally, we were pleased to have the opportunity to talk about what some of those changes, as far as we know about them at this stage, of course, may mean for us as NHFT and KGH. So we were joined by Eileen Doyle from the Northamptonshire Integrated Care Board to start helping us thinking through what these might mean. And we also then spent some time in that workshop sharing our experiences of working in NHS group models. So both KGH and NHFT are working in different NHS group models. So we were able to compare and contrast our experience and learn from each other's. So hopefully governors that were able to participate in that workshop found it useful. Of course, as with all of our workshops, we have materials available for you, whether or not you attended. So do let us know if you'd like us to send you some materials, and indeed look out for the date of the next workshop, which will be hopefully coming up very soon. Staying on the workshop theme, we most recently had another workshop between the Council of Governors and the Board of Directors. This is an annual opportunity within the organisation, in addition to the opportunities we have through these sorts of meetings, to come together in a more informal environment in a workshop setting between the Council and the Board. On this particular occasion, the theme of the workshop was the Care Quality Commission's inspection regime, and we took the opportunity to think through together how we might then approach an inspection, what our respective roles and responsibilities might be in that inspection, and more importantly, I think, talked about some of the challenges we're grappling with and some of the things that we think that we are doing really well that we want to celebrate as and when we receive a visit from the Care Quality Commission's inspectors. And indeed, we built on that conversation for a specific governor workshop that we held this morning just before the meeting. We've also been maintaining our series of meetings between governors and non-exec directors, which we call our constituency meetings. We had one of those on the 10th of July, and the focus of this one was on children and young people. The reason we focused on this particular topic in part because this is one of our membership priorities that the Membership Engagement and Representation Committee of the Council agreed to focus on. So very pleased to be joined by Georgie and Rachel from our Children and Young People's Services, who talked us through a real wealth of things that are going on in the world of participation for children and young people. So we heard about the work of the Youth Advisory Board and the range of opportunities that exist for our young people in getting engaged and involved in some of our services and indeed helping to shape our future service model. I know a number of people from the council attended that workshop, so again, hopefully people found that useful. We're certainly building on that relationship that we formed with the Children and Young People's team to take forward the membership priority on engaging children and young people, and we've got some more information coming up at the Membership Engagement Representation Committee meeting that's taking place later this month. And then finally, before I hand back for any questions or comments, or indeed contributions from other governors actually from this month's report, I must plug the annual public and members meeting, or the annual general meeting of the Council of Governors, which this year is taking place on the 15th of September at 5:30 in the evening. We're holding the meeting via Microsoft Teams, largely because we find that that's the best way of maximising engagement and attendance at our events. So this year we're going to be focusing on our new Thrive strategy, so that will allow us the opportunity to reflect back on the final year of our Digby Q strategy, but also to look forward as to what the new Thrive strategy gives us in terms of opportunities for the future. Based on learning from previous events, we've found that people quite like the opportunity to have some case studies of work that's been happening in the organisation. So at this stage, we're planning to hear from our intermediate care team, the ICT, on some of the work that they've been doing, and also from our colleagues in mental health services who are in the process of switching to a new method for understanding and managing risk within our mental health services. So do, if you haven't already, put the annual public and members meeting in your diary, 15th of September at 5:30 on Microsoft Teams. I would encourage you all, of course, to go out and promote the event to others. We do want to maximise engagement and attendance from the wider population, and if you are looking for some resources to use for publicity, then do drop us a line at the Foundation Trust office, and we can furnish you with some materials to use. Of course, we shall also be doing some promotion work ourselves corporately. You'll see at the back of the report some upcoming meetings and events, again, dates for diaries. So I don't know whether anybody from the council wants to highlight any work that they've been doing in terms of membership work themselves. Whilst people are having a think about that, I'll bring Tracy in. Tracy.
I just thought I should clarify, because it was mentioned we have actually stood down the membership meeting later in the month, just because I think we've hit holiday season, so a lot of people are on holiday. But I thought I'd just brief governors that doesn't mean that the work has stopped on the membership work or programme. As I mentioned, I think this morning, we've got our meeting next week with the spiritual wellbeing lead and team, which I believe Monica and Anu are attending, to hopefully get us thinking about how we can connect governors to faith groups. I've also had a meeting this week where we're actively planning a joint member event with Kettering General on veteran support. So that's a bit of a watch this space, because we're still planning that one. So there's lots of work going on. And also, as I've put in the chat, Georgie did say at the constituency meeting that governors, if they want to attend the Youth Advisory Board to connect with that group of young people, then there is an invite. You just need to let us know when you might wish to attend so we can book you in. So that was just a bit of a plea, really, if any governors want to attend.
Thanks very much, Tracy. And certainly those governors that attended the last Youth Advisory Board meeting spoke very positively about the opportunity. So yeah, a recommendation there, I think, from previous governors. Okay, I can't see any other hands from governors wanting to share work that they've been doing, which is not to say that there's not work going on, because there is an awful lot going on. But I'll perhaps then, in which case, Julia, hand back to you. Thank you.
Lovely, thanks, Richard. Really comprehensive, clear slides and lots of information. Clearly, a lot of work and a lot of activity going on. So thank you to you and your team and to governors that have been out and about. Just one last thing, Richard mentioned a workshop we held this morning that I know not all governors could attend, looking at CQC and the framework and the governor's role in an inspection. Just to say, we recorded that, and I know that will be available for other governors who weren't able to attend that this morning, if you want to have a look at that. So thank you, Richard. Lots of activity, lots of really good stuff in there, and thanks to everybody involved. Okay, we'll move on to our next section, which is assurance-based, and updates from both myself for Krishni and from David Mayer on behalf of Angela. So the two reports, the Chair's report to the board and the Chief Exec report to the board, to the July board, were actually sent. I think there's a link in the invite out to governors, so hopefully you've had a chance to look at those papers. If not, I do encourage you to have a look. They're really good summaries of what's happening and what's been going on over the last couple of months. Krishni asked me just to draw out a couple of points from her report to the board. One was to confirm that our fit and proper person process, looking at the fit and proper aspects of all board directors, the process concluded, the submission was made on time to NHS England, and we just need to confirm that that happened. And just to say that her own appraisal, Krishni's appraisal as chair, was also submitted on time through to NHS England. And I know the private council have an opportunity to look at that a little bit later on. So I didn't have anything else to draw out, unless there's anything anybody wanted to draw out from her report to the board. It's full of all sorts of activity and lots of things that have been happening. If not, I'm going to invite David Mayer to just talk us through any highlights from Angela's report or anything that's top of his agenda that he'd like to share with the governors this morning. Thanks, Dave.
Great, thanks, Julia, and yeah, good morning, everyone, and welcome to new governors. I've had a chance to meet both of them through the accountability structures that we've got at local authority level, so great to have you on board. Just a few things just to flag. Colleagues will recall we updated on the consultation process for the 10-year health plan for England, described as Fit for the Future. That process has now concluded and the plan has been published and is hyperlinked in the document, and it sets out a set of broad ambitions across the three shifts, analog to digital, acute care to community care, and treatment to prevention. We're gathering ourselves around that. We've got a strong programme of work emerging around neighbourhood healthcare, being the framework that certainly at a policy level, the intention is that we see much more alignment of healthcare provision at local area and neighbourhood level, allowing us to really deliver that shift of inpatient acute setting care to a much more dispersed open model with primary care and services like our own in community services and mental health services, plus our children's services, of course, working through with local authority partners. So that's a really exciting opportunity for us, and it's a space that we've been in for a long time. And I've said before, I think in this forum and possibly at Trust Board, as a trust, we're really fortunate here with the fabric of our estate, with great sites throughout both local authority footprints in North and West, which really stands testament to our ambition really to further bring healthcare resources closer to people's homes and closer to their families and places where they can thrive and prosper. I've used a good quote from Nigel Crisp, who was previously an NHS chief executive, who wrote a book after his tenure described as "Health is made at home, hospitals are for repair." And that really does ring through our ambition through Thrive, our new strategy, that health really is made at home and in local communities, and that's a space that we're really kind of positive and assertive in working with our communities and our partners in. Aligned to that, there's a neighbourhood health implementation programme. We're putting forward proposals with primary care and others to take some leadership in that. Certainly in West Northants as a pilot site, there's only one option in a geography such as ours, and we've been working through that with partners, and hopefully we'll be able to feed back in due course progress on that. We've also had an update on our oversight framework for 25-26. So these are the national measures that are used to assess our performance in delivery against access, safety, workforce, finance being the key metrics. It's fair to say we're doing pretty well in a lot of those areas. Our waiting times are continuing to reduce across services. We're making good progress in our mental health services, and indeed our children's services equally are continuing to improve in partnership with our colleagues and partners in the system. There is a sense within the oversight framework that the finances are really, really dominant in assessing providers' capability going into 25-26. We have a strong value programme in the trust, but some really, really stretching expectations in terms of what we will deliver financially this year. And in the paper, we mention some of our workforce plans, which again are set at a national level in terms of reducing numbers of whole-time equivalencies, and we're going through a very managed process to allow us to do that without compromising services and patient safety. But I just flag for Council of Governors, Julia, that the finance environment that we're operating in is really, really challenging, and that's across the NHS and indeed the public sector. So just to flag that, but we have plans and remain confident that we will be able to manage that. Also in the paper, I just pull out, as a consequence of Penny Dash, who is the chair of NHS England. Penny's done a review of some of the other architecture that sits around the NHS, which is detailed in the links in the paper. But there is a proposal that the National Guardian Office begins to be subsumed within the wider Department of Health safety structures, and thus the NGO the National Guardian Office would cease to exist. I just want to reassure people, and Monica has given us a good testament to the importance of this, that we continue to place freedom to speak up at the very front of everything we do. Angela is the accountable executive for that. I line manage the team, and we have combined sessions with the chair and non-executive leads on freedom to speak up. So just to reassure people that whilst some of the national framework might be changing, nothing changes for us internally. If anything, we would be looking to step up our freedom to speak up profile across the trust as we move into taking on other services, which I'll talk about in a second. Also, just want to bring to attention of Council of Governors, the ADHD task force is now beginning to report, and colleagues might recall that I updated on this previously in relation to some of the challenges we were seeing across services with really, really long waits nationally for ADHD diagnoses, and the neurodiverse pathways were being really challenged post-COVID. That task force is now beginning to set out some helpful clarifications, I think, about the role of specialist providers such as NHFT, and beginning to describe what the role of other resources such as primary care might look like in supporting people get access to diagnostic support and indeed lifestyle support in terms of living with ADHD and or autism. So we're really plugged into that, and also helpful is a recognition within that report that prevalence hasn't increased in those pathways. What has changed is that people are more aware of their needs and they feel more able, so there's less stigma with them expressing the needs that they have. And that's really positive. We would want that for all our services, for people to feel confident and to enter into a non-stigmatizing conversation about the support they need and how we might help them. So I just reassure people that's work in progress, and obviously quite important, because I know our communities are struggling with that nationally and locally. And then just to update on some of our long-serving colleagues, just to recognise them through the Council of Governors. And again, Monica's reminded me and us of the importance of everyone in providing a good social fabric to the services we provide and to healthcare. We had 2 colleagues with 50 and 51 year services, which is phenomenal. And I shared a table with John from Hotel Services, and it was a really special memory, just thinking about the different sites that people have worked on, that worked in, that are no longer part of the trust, but you know, that sense that we are just custodians for this period of time in supporting our communities with their needs. And it was just a warm event, so thank you for those who contributed. We're also in the process of taking on prison healthcare or secured services healthcare. Some of them are, well, not all of them are prisons. There's an immigration centre included in this across Nottinghamshire and Lincolnshire. This builds on our current footprint in Bedfordshire and Peterborough and elsewhere in providing secure services. And we're in a transition process. We've had Loudon Grange come on board in the last couple of weeks, and we'll be stepping into those other services between now and into September, October. So a really important opportunity for us to not only build our profile in delivering care from cradle to grave, so from, you know, early years services right through to end of life services, but also our social justice commitment to providing really good healthcare to people who are disenfranchised or facing challenges or struggles in their lives and are part of the custodial system in our prisons. So that's an important part of our value set, and we're really enthusiastic about trying to make a difference in that space, which is really what we're here to do. And then finally, just to call out a couple of colleagues who, Joanne Fitzgerald from our Hotel Services has been named Public Sector Catering Manager of the Year, and equally Kerry Healy, who works also in our Hotel Services, as a finalist in the Chef of the Year award. And I thought of them, Mabel, when we were having our workshop a couple of weeks ago, where you described kind of members of the public describing how professional and clean and how good the food was in our facilities. And it's really great to see actually that being manifested in colleagues winning awards. So again, really proud of those, so well done. And also just to call out Ian Graham, who's been a long-standing colleague in the trust and also a representative on our staff side, the interface we have with our trade unions. He's been recognised by his Royal College as being Steward of the Year in 2025, and just want to recognise that here through this forum. Thanks, Julia.
Great, thanks, Dave. Really, really, really important to share with governors some of those successes, and you know, our staff go daily above and beyond, and to just be able to celebrate nationally and locally some of those achievements is fantastic. But the Long Service Awards, that's amazing. 50 years, I mean, that's just stunning. So thank you for sharing that with us. And just before I invite people in, for me, the Freedom to Speak Up Guardian's Office, I'm really pleased you brought that up, that our commitment is as strong as ever, and it doesn't matter what the mechanism is, and nationally we absolutely will continue with this, as it's an important part of who we are and what we are. So really, really important. And also thank you for being honest about the financial situation. I think it's really important that we're all you know, appraised of the realistic situation that we're in, but assured that we look at quality and safety behind every decision that we make. And we certainly see that through our committees, etc. Great, thank you very much. I'm just going to open it up to folk for comments and questions. I can see Adam and then Michael. Thank you. Over to you, Adam.
Thank you, Julia. Thank you, Dave, for that update. I've already said in the chat, I was heartened to hear your update around the situation regarding very challenging circumstances for people awaiting ADHD and indeed autism and other neurodivergence diagnoses. I haven't read, I think like an interim or some early findings report was published a few weeks ago, and one of the things I remember seeing in the highlight for that was that because of the diagnosis situation, the long wait that can amount to several years, that one of the recommendations was around employers and others supporting people who are even suspected as being neurodivergent with various what's the word, adjustments, such as, you know, quiet spaces and noise cancelling headphones and all the rest of it. Well, one of the things, so thank you very much for that update, but one of the things I just wanted to follow up with is, I know the academic research is a little bit patchy around this, but there's an indication that there's a greater prevalence of neurodivergence such as ADHD amongst people who work in areas such as healthcare. I know someone who's a lecturer, who's lectures paramedics, and she says that she thinks the prevalence is very, very high. And so I was just wondering whether the trust had any thoughts around how they might support neurodivergent staff, given the challenges around diagnosis, and also what you were saying that in modern day there's a much more awareness and acceptance of neurodivergence. And so, yeah, just be keen to hear if there's been any thoughts around that, or if there will be. Thank you.
Great, and thanks, Adam, as ever, for your kind of enthusiasm in making sure we focus on this. I'll bring in colleagues. Certainly, our Enable network are doing some work, obviously supporting colleagues. I know Melanie will come in on that, and Itai, as our medical director, hopefully might be able to say something about the prevalence. I know it's about 3 to 4% at a general population level. I'm not too sure about the overall prevalence in healthcare services or healthcare workers, but I'll ask Itai to make a contribution on that, if that's okay, Julia. Yeah, okay, thanks, Itai.
So I don't have the figures at my fingertips, Dave, I'm afraid.
Don't worry.
About the prevalence of neurodiversity, but I am aware of the significant impact that it has on our waiting times, particularly in community pediatrics and in CAMHS and in our adult mental health services. I think, what can only be described as an avalanche in terms of referrals has led to, quite a lot of pressure on services. And the difficulties that we face are that to be able to diagnose, autism and ADHD, you need some really robust assessments. And if the assessments are not robust enough, you're betraying both, the patient and the family. And it's important for that to be done in a very systematic way. So what tends to happen is that we have got some disparities between how we do it in community peds and how we do it in CAMHS, and we're learning from the way we use multi-care professionals to address waiting lists and improve that capacity to undertake assessments at pace and to make those assessments a lot more robust. Certainly, I suspect that is why Melanie has got her hand up. We had a recent service visit to the community peds department, and we learned a lot from the frontline clinicians who are managing, those waiting times and those waiting lists, about the ideas that they had for, for managing that. And I took an action which I've already sort of implemented, which is about sort of bringing colleagues together and learning how we can sort of have a clinically driven, service redesign to improve our capacity and management of those waiting times.
Thanks, Itai. And actually, before I bring Michael in, Michael, would you mind if I'm not sure if your comment was around this particular aspect. I just wondered if you'd mind if we just close this bit off first. That would be great. Thank you. I'll certainly bring Melanie in, but also just draw your attention, Itai and David, to Laura's comment in the chat about our current wait times for assessment. If there's any sort of commentary you could give us on that as well as part of this response, that would be helpful. Melanie, did you want to come in?
Well, yes, just before maybe David comments on that, I wanted to talk about the workforce support, picking up on your point, Adam. And David was absolutely correct, of course, that the Enable network, which is our staff network for people living with disability or a long-term health condition. I should just point out that I don't see neurodiversity as either of those descriptors. But having said that, the Enable network over the last couple of years has done a lot of work to support and develop communities of support for people with a wide range of neurodiversity, such as dyslexia, autism and ADHD. And particularly in the last year, we set up a neurodiversity peer community group that meets routinely. It's an informal group, so that means that it's a meeting, a Teams meeting where people can just come and chat, and there's a WhatsApp group that supports it as well, I believe. But I should also point out that staff also have access to some of the neurodiversity support programs that are available through our Recovery College and through iDiscover, which is a web-based kind of fact and support repository, I guess, for articles and assistance aimed more at children. So staff can also tap into the patient support elements that you can find there that helps you understand diagnoses, but also offer support on living with neurodiversity and other sort of, and signposts sort of other support networks, because of course there is a lot of third sector support for neurodiversity as well. So that's just from a staff in particular. Julia, thank you.
Thanks, Melanie. Dave, did you want to come back in just to close this up?
Thanks, Julia. The task force is really important because we're not resourced for the current level of demand that we see in services, and that's why waiting lists across the country are so high. So the task force gives now a kind of an evidence-based analysis which allows commissioning conversations to happen about how relative resources are aligned to supporting a diagnostic pathway. So just to kind of emphasize, that's really important. We have had people waiting up to 4 years for that. In some parts of the country, it's 5 to 7 years for people getting a diagnosis. And the other thing I'll just say very briefly is we have, as a consequence, not just of long waits in these services, but also because of demand that we saw post-COVID, developed a really, I think, comprehensive waiting well program, which allows us to, where people are waiting for maybe a diagnosis or additional hands-on physiotherapy support, that we provide them with a set of resources and access to support which allows them to wait well. And some of that has had really good impacts. Certainly in our MSK pathways, we've seen some people come off the waiting list because actually the intervention they received whilst they've been waiting has been sufficient to manage their needs. So I just want to reassure people that whilst we are dealing with those challenges nationally in terms of resources, we also do have a framework to try and support people during that process.
Thank you. Really, really important part of that. So Laura, do you feel we've covered your question in the chat? Just double checking.
It was actually my question, Julia. It's Robin, but
yes,
sorry, thank you very much.
Robin,
It was just to provide a bit of context around the conversation, so thank you.
Great, lovely. Thanks very much. Thank you. And also just I draw people's attention to the chat because various people have responded and put in some extra information, which is really important. David Williams there about reasonable adjustments for staff and providing a positive place for people to work. So I think that's a really important point. And everybody else, thank you for your contributions there. Lovely, thank you. Michael, sorry, many apologies for making you wait, but I thought it was worth just finishing that part of it first. Over to you.
Yeah. No worries. Thanks so much, Julia. I've just really a couple of comments, and then I'm afraid I have got a bit of a challenge in part of the report. So I would just to emphasise the fantastic achievements for staff, because I think they're many and varied, and given the sort of the challenges across the NHS generally, I just think fantastic, and it's great that the organisation has also enabled people to develop and achieve, get those successful achievements. I think in terms of workforce, with my nursing hat on, I would just say that obviously in terms of the financial situation and potential reduction in workforce, just a plea to consider the challenging issues nationally around newly registered nurses and their ability to attain work, etc., etc. So, you know, I'm not asking for, you know, an opinion on that. I'm just putting that out there as an issue, that there is a potential impact for newly registered nurses. And also in terms of the paper relating to the ICB and the interim chief exec role, I guess I would just also sort of raise the issue that there is an ICB, Integrated Care Board, in, I think it's North London, where the Director of Nursing role is being removed from the future senior leadership structure. So professionally, I would raise that as a serious concern. And I hope that in terms of the local arrangements, in terms of the ICB, any discussions about the future leadership team, it would be helpful to have an appraisal about that. But, you know, I understand that might not be within the remit of the Council of Governors. But I think it's a really serious issue. We've talked about organisational change in the past and the loss of organisational memory, but this is a significant issue about leadership and the wider clinical contribution that post holder brings. So I know it sounds a bit sort of party political, but I think it's really, really important to flag that as a serious concern. I think my challenge is, if I take us back to the paper and the Mars scheme, I'm just interested to see that the Mars scheme has been described to best meet the needs of patients, service users and carers. And I'm just interested how the organisation has chosen to describe the Mars scheme as that, because actually this isn't really, this is really a scheme to assist people leaving an organisation as part of the wider workforce reduction. So I'm not quite sure how it's been positioned to best assist patients and carers. So that's the comment that I would like a response, please.
Great, thank you, Michael. And we certainly note your concerns on some of those other areas too. I don't know, Dave, whether you want to come back in, if that's okay.
Yes, thanks, Julia, and thanks, Michael. And just on the graduate nursing roles, I know Nina Morgan, who's the regional chief nurse, is also really keen that providers keep an eye on that pipeline of people coming through. You know, the process of managing our overall workforce numbers does not necessarily prejudice us in terms of taking on newly qualified staff. So I agree with you. That's really important that we maintain that pathway. In terms of the benefit for patients, and so the Mars process is really, we're trying to identify colleagues in the organisation, non-clinical colleagues, who are able to make a decision about moving on from the trust in a supported way. And that benefits patients because we are not targeting clinical services. We are not seeking to manage our financial pressures that the whole NHS is facing from needing to trim access to services. And that's really important. And the Mars scheme helps us do that because it helps us identify in the organisation where people are prepared to move on from the organisation, and to do that in a structured way which maintains ongoing clinical services and frontline care. That's in essence why it's really important for patients that we approach it in that way.
Thank you. Michael,
yeah, well, I'd have to say on this one, we may have to disagree on this, because I think that historically the Mars scheme is not described in terms of the best interests of patients and carers. This is in the best interests of the employer, although I accept that in terms of how decisions are made, you do need to take into account the impact on services as well. So thank you for letting me say my piece on that, and thank you for your reply, Dave. That's the good thing about our meetings, where we can have a challenge and we can have a good discussion. So thank you.
Absolutely. Dave, did you want to come back in?
Yeah, no, and I agree. The approach we use at all these discussions, and it is a difficult time in the NHS for all provider organisations. The workforce expectations are not ours. They are set generally from the national planning process and it's one of the reasons the ICBs are clustering, is that they are being asked to remove 50% of their overhead costs. So whilst I agree with you, Michael, that it is a benefit to the organisation, ultimately the organisation is responsible for providing statutory healthcare services. So we are trying to do what is required nationally in a way which safeguards our statutory requirement to provide, comprehensive healthcare services. So I recognise the tension there, but ultimately we are trying to do it in a measured way which maintains that integrity of service provision.
Thank you. And again, thanks, Michael, for raising it. That's exactly the point. There's some, very difficult challenges, but we need to have the open and honest conversations in public about how we're going to approach them and what decisions we take. So thank you both for that. Just a couple of things before we leave this. I think Robin might be coming in to say what I was just going to say on his behalf. Robin, did you want to come in first?
Probably, Julia. We usually think alike.
Go for it.
In the chat, there's quite a lively discussion going on about waiting times and waiting lists, and important to register this, that this is something that we look at constantly, both in quality and safety and in performance and at board level. So this is an area that receives a lot of attention, but it's dynamic and it's changing all the time, and sadly in some areas it is getting worse. The waiting times are increasing in some areas. So I think there's a clear interest by governors to see some sort of update at a future meeting. Can't do it justice today, but an update at a future meeting as to how our Waiting Well initiative is being rolled out and continued to operate. So I think there's something for the agenda, Richard, for a future meeting.
Thanks, Robin. That was exactly what I was going to pick out. So I'm really glad that you've done that. So they're not listening to my voice constantly too, a different perspective. And actually, thank you, Heather, for raising that, because there's an awful lot of work going on around people trying to help people wait well. It's never easy to wait. The impact on families, children, it's very, and adults, it's very difficult. But we certainly could bring you some of that assurance and some of that detail, because we do look at it periodically through various committees, etc. So thank you for that. So thank you, Dave, for your update. There's been a lot of really useful conversations come out of that, and I think that's just the richness of being able to present what's concerning and what's going well at the moment. So thank you for that. Pete, I was just going to go back to you, put a comment in the chat after we'd moved on from Richard's Council of Governors report. Just want to bring people's attention to an event you attended on behalf of governors the last month or two. So thank you very much for that. Okay. I'm going to move on to our non-exec director risk and assurance topic, which is around service visits. So I'm going to hand over to Melanie and to Joe to talk you through the process and the assurance we gain. And I know that the slides are going to be put up for you. Great. Over to you two. Thank you.
Thank you. I'm going to kick us off and then I'll hand over to Joe. Particularly around areas of how we get assurance. But service visit seems like a really timely topic, doesn't it? Because we've mentioned it such a lot as part of our evidence when we're discussing a CQC inspection, but also how we learn. And there's been a number of references to service visits already during the workshop this morning and the meeting so far. So, I mean, service visits, if we move on, thank you. Is it Joe or Tracy driving the slides? Sorry. I mean, service visits have been a key feature of the governance approach for many, many years. I mean, I joined, 8 years ago now, and, certainly I started off doing service visits right from the get-go. And they really help us know our business, run our business, and improve our business. And I'm going to come back to that in a little bit more detail in a minute. But it was also an area where there was some good advice in our external well-led review last year, which really suggested some increased focus around how we prioritise and ensure there is a good cross-section and variety in service visits that are undertaken across a wide range of services. And then also looking to bring some sort of additional transparency into the way that service visits and actions arising from service visits are reported and reviewed within our governance processes. Now, as we've heard, we all are continuing to participate in an increasingly well embedded, I think, and well supported programme of service visits. And for governors, for example, if you would like to participate in a service visit, you can reach out to Richard's team and something will be arranged. So we are sort of managing the spectrum of service visits more effectively now, I think, than we ever have before. And oh, Pete's just obviously dipped out and coming back in. And also we have increased the assurance around our service visits, as Joe will explain in a few minutes. And service visits now report up to the Quality and Safety Committee with a great deal of scrutiny by the leadership and executive team during the process of that reporting. So if we move on, I mentioned about knowing our business, running our business and improving our business. And this is all fairly, it's not rocket science, is it really? The fact that if you get out and about, get out into our services, you can develop first-hand knowledge of the work being done. You can build relationships with our teams that you might not otherwise be able to do, and you'll gain knowledge and assurance during the conversations that you have to underpin what you know and understand from committee and board papers. In terms of running the business, then leaders, of course, have an increased visibility. And I should point out at this point, I'll come on to it in a bit more detail, but it's not just the non-execs and governors who undertake service visits. It's our leadership team right across. We expect team leaders to undertake service visits and sort of floor walks as an essential part of their role. So leaders right across the organisation, by spending time in the services, have an opportunity to see what's going on and have better decisions as a result of all of that knowledge and that rich discussion that we have with staff and patients during the visit. And those first-hand views from trust experts, the people who actually know what it looks and feels like on the front line, if you like. And then, of course, from those service visits and from conversations with the frontline comes the opportunity to drive local improvement and indeed trust-wide improvement. It's an opportunity to hear about things and to signpost staff who maybe have great ideas as to where they can go with those. And as an example, I was on a recent service visit with Itai where he was encouraging the team to use Dragon's Den as a means of accessing some additional resource and funding. So it's through those service visits that we can really get a sense of improvements in innovation that are already being made, but also prompt and signpost and bring back to wider discussions the ideas that are being generated. So the next slide's a little bit crowded. I thought rather than sort of talk you through all the words, because you'll see the presentation afterwards and you can read it to your heart's content. There are 5 different types of service visit as we would articulate it, and I thought I'd maybe just give a few examples. So the first one would be based on our routine process of getting out and about around services. And that's where an executive director, normally with a buddy non-executive director or any other non-executive director who wants to get in on the act, and hopefully a governor in most instances now, make a visit to a service to learn, to understand, and to listen to challenges. So Itai actually mentioned a good one. But I actually wanted to focus on one that I did with Pete Spink in the Willows. And Pete will remember this, I'm sure, with David Williams. The Willows is a respite centre for learning difficulties, learning disability adults, in short. And we learnt such a lot about the service actually provided, the support, the challenges around, a little bit around capacity. We got a great overview of the development going on within the team, we got a real sense of the whole team spirit and seeing the culture and the values of the trust writ large, if you like, across the whole service. So that was an excellent example, I think, of this type of sort of routine service visit. And then the second type, in actual fact, is where we're responding more to specific themes that may have come up at a board or committee. So this is where Itai mentioned a good one earlier, I should have said, community paediatrics, with which Itai and I visited a couple of weeks ago. And we were really focusing in on some of the challenges around waiting lists, but also the team raised with us challenges around estates and, again, facilities. They shared with us some great work they were doing on the speech and language therapy waiting list, again, coming back to this concept of waiting well, where they'd been undertaking a survey and review of the list, and also some shared learning they've been taking forward with Leicester Partnership Trust. And that's where Itai signposted, use of Dragon's Den as a means of driving forward some further innovation. So it was a really comprehensive give and take, I think. And again, easy to test the focus that the team has on well-being, staff, recruitment and retention, and then most importantly, easy to focus on how the team and the service was focused on patient care and carer and family care and impact for the services. And another good example in this area would probably be prisons. And I think most of the non-executive directors have been out and visited prisons in the last year, as the focus from various inspections, but also the recognition of sort of prisons maybe being on the outlying edges of our service. And Judith, I think, has most recently been to HMP Loudon, which is one of the new prisons that we've taken on. And so all of these are great examples of where we're particularly focused on a service in order to answer a particular question that's been asked in a committee. And then the third one there is just where you have an opportunity, something crops up. It might be a special event. So, for example, a year or two ago now, I went to the 5-year birthday celebrations of the perinatal service. Or it might be us dipping into the various cultural events that take place across the year, Black History Month and at the moment South Asian or Pride. So examples of where there's an event going on and we'll attend. So later this year, I'm sure I'm not the only one, I'm going to the Allied Health Professionals annual conference, which is a day in September, I think it is. And then leadership conferences is another good example. So these are where we have an opportunity, particularly as non-executive directors, to attend these events. And they are a rich source of discussion with staff from right across the trust normally. You learn an awful lot. And to be quite honest, from those, a lot of other service events get triggered as you have these interesting conversations and you think, oh, I'd really like to go and visit that service. Or they have a particular challenge they're raising with you and you think, I'd like to come and talk about it with you more. So they're the three main service visit types that the non-executives and executives get involved in. But on the next slide, we do refer to the leadership team, and senior leader walk-arounds and quality and safety visits, which Julia would also potentially be involved in as the quality lead. And these are, as I say, what we expect to happen root and branch down through the organisation. The use of service visits and discussion to really enable us to check and assure about performance, quality, safety, and efficiency, and the challenge of some of the questions that you've been posing, Michael, earlier in today. So we do all these visits. What then happens? How do we kind of make sure that the assurance is proven? And I'm going to hand over to Jo now. And Jo, you might want to share one or two service visits of your own as further examples, but I'll hand over to you.
Thanks very much, Melanie. Hello, for those who don't know me, I'm Jo Lancaster. I'm an Associate Non-Exec Director. I've been with the Trust now for a couple of years. And from a personal perspective, my background is local government. So I have, 30 plus years of knowledge of how the local government system works. But service visits for me have been an absolutely essential way that I start to understand how services work at a very, very personal level, how patients are introduced to our systems and how they're managed. So for me, it's been absolutely essential to get that degree of understanding from the front line. So, as Melanie hinted at, one of the things we've been working on over the last 8 or 9 months is how we tighten up the outputs from the service visits that we undertake. Because at the previous to that, we went on service visits, we shared notes, and there were informal channels of feedback. What this slide is attempting to do is to show you the new version of how we use the information that we get from service visits. And as we say, this has been evolving since the end of 2024 to give more consistency in how the feedback is used. So at the top of the chart is the action that Melanie's just talked through, the process of going out to one of our locations or meeting online to undertake a service visit. And then what flows through from underneath that then is the process by which we as non-execs and the execs gain confidence that the outputs from the visits add to the quality of care and service delivery. So I won't read it verbatim, but essentially the next box down is that we have a standardized approach now to capturing the process of service visits. And Heba alluded to it earlier, but she and I had the pleasure of a visit together to Yarlswood, which is again part of our secure services portfolio. And we went along with Anne Rackham, who's the Chief Operating Officer, and we have a standard approach to the minimum amount of information we want to take away with us. And that feedback will be gathered together and it'll be contributed to by the non-exec quite often, but also by the exec. And we'll compile that into a standard feedback form. And that ensures that we have a point of comparison across the different visits. So whether you visit Children's Paediatric Service or whether you visit speech and language or musculoskeletal or some of our inpatient wards, there will be a consistent way that information is gathered. So as non-execs and execs, we can literally compare across. The next stage from that is the information is synthesized down into what we call a AAA report. And a AAA report is a standard reporting template that comes through our level 1 committees. And what the AAA stands for is it includes alerts, so things that the committee should be focusing on, things that actions may need to follow from, things that may need further follow on. The second A is advise, so things that we found that may be of interest and relevance to that committee or possibly to other committees. And then the third A is assure, and that's to give confirmation that what we found is in line with what we're expecting. We also include on the AAA reports risk, if there's something which may be a medium-term risk or something that we've spotted that may turn into an issue later on. And then we also, really importantly, capture things that we want to celebrate. So, celebrating outstanding activity. So just to give you a few examples of what those sorts of things might look like. So an alert, for example, we had a process whereby we had a review of all of the service visits that have been undertaken recently, and it went through, as Melanie said, the Quality and Safety Committee, and we took a complete overview. So an example of an alert might be that one of the visits to one of our estates, Brookview ward, there was a faulty lock found on the ward door from the patient area that went through into the staff offices. Obviously, something like that is really important to be dealt with very quickly. So it was highlighted as an alert so that the executive team could take action, but equally that the non-execs would then be confident that the matter would be addressed. But also in the short term, that the risks associated with that problem could be managed within the ward environment. So an example of advise, so that is ongoing monitoring, development, that type of thing. It was a service visit of my own. I went to the 0 to 19 services run out of Campbell House. And in talking with the team there, they were raising concerns that the trust's sickness policy wasn't necessarily allowing them to manage sickness as well as they might do, which was then putting pressure on staff vacancies, gaps in the rotas, the need to buy in agency staff, which was having budget impacts. And they talked through the things that were causing them concern. And as a result of that, the matter was identified. It was presented then to the internal wellbeing steering group, who then took the view of reviewing our sickness policies to make sure that they were equally balanced between the person who was sick, but equally giving the manager the tools that they needed to manage that sickness and return to work successfully. And again, you know, if you think about the opportunities, I think Melanie's already referred to ITI and the reference to the Dragon's Den. Again, that same service group was saying to us that it would be really useful to have some way of using modern technology to help in note taking, or where there were people whose first language wasn't English. So maybe there's some sort of translation service that could be looked at just to improve productivity and help patients feel able to communicate effectively. And again, the Digital Data and Technology Group then took away that as a task to have a look to see whether there were some opportunities to pilot, perhaps using technology to help in that process. And then Assure, so the final A, was that bundle of things where board were being advised that assurance was given and taken from the service visit. An example on that one was a visit. I visited quite a lot of the prisons, and one of the visits was up to Whitemoor Prison, where they were talking about problems in recruitment. There were 3 vacancies, but they were doing a really good job of holding on to staff, but also very good at recruiting staff, which allowed us then to share some lessons from HMP Whitemoor with another service I'd visited, which was a prison, which was HMP Swinfen over in Staffordshire. And they were finding it really hard to recruit staff because there was some confusion, because although it was a Northamptonshire advert that was going out, the job was actually based in Staffordshire. So again, we could share learning, but again, give the board assurance that things were progressing really well. So that's the AAA and how it affords us the opportunity to capture systematically the learning from service visits. And then what you see at the bottom of that slide is effectively the 3-pronged route where information comes out of those AAA reports. And the critical thing, I think, for governors to have confidence in is that because we're being systematic now in how we capture the information, that review process is really tight, so that we keep that quarterly reporting, so that everybody has an understanding of what's going on, which services are being visited, and equally which services we may then need to put on the next round of service visit programming. So I'll move on. There was a question from Michael about the flowchart, the Crystal programme. I'll throw that one over the fence to one of the execs. So Dave Babick, if you could pick that up in the chat and just pick up Michael's answer, that would be great. And I'll move on to the last slide in the pack, which is just in terms of the ground that we've covered so far. So this gives you a breakdown of a snapshot of just March, and it gives you an idea of the spread of service visits that have taken place. So during March, most of the visits, 60% of the visits, were conducted within the Mental Health and Learning Disability Directorate. Some of that was to do with waiting lists, and the fact that we did have a big demand for those service areas. But again, you know, that number will change, and every month there will be a different profile of services under visit, as Melanie said, for one of those different 5 routes into the service visit process. But the final point from me is just that feedback loop. So quality and assurance is gained both from the process of talking to frontline staff. As non-execs, we have that access to people who are experiencing service delivery, and where appropriate, we also get to speak to service users. But the flip side of that is we also have that systematic process whereby we capture information in a structured way, which allows for that consistent point of comparison. And as that final bullet point says, the route through which that flows through into board is through the Quality and Safety Committee. And if there are issues to be escalated, obviously the escalation route then is through to board. So I'll finish at that point. Adam, yes, certainly Governor feedback. I think certainly when Heber and I visited Yarlswood, we had the conversation about the important things we wanted to include in the feedback. So I would encourage you, if you are visiting as a governor, at the end of the service visit, just agree with your non-exec and exec who's there with you, just what are the main points, what are the main learning points that are coming out of that process. And if it helps governors to think about it in that structured way, the AAA report, as I've referred to previously, that's the lens through which we see things. So again, you know, the AAA, alert, advise and assure, those are the 3 points of reference. So I think I'll pause at that point, and I've obviously not missed anything out because Melanie hasn't jumped in, and pass it back to Julia. Happy to take any questions if we're able to, and thanks, Dave. And it's Richard that's responded to Michael's question. Thank you.
Great, thank you both. Really comprehensive overview of our service visit process, and some great examples in there of some of the learning and some of the assurance that we gain through those visits. We have got a few minutes. We've got till 5 past. If has anybody got any other comments? There's quite a few in the chat, and I know various people are trying to respond to those. I didn't know if there was anything particular anybody else wanted to bring up about the service visits. A few colleagues are having to leave at the moment. Michael.
Thanks for bearing with me today and all my queries.
No, it's fine. That's what it's for.
I just wanted to ask, in terms of what you were doing before and the current process, what feedback you get from the departments and areas that you visit? Because historically, one of the challenges is, of course, is that it's great to see people, but sometimes organizational systems don't always give them the feedback that they thought they were going to get after a visit in terms of actions, etc. So it's just interesting to hear how you've learned and developed.
Great, thank you. I'll pass over to the other two, but I personally know that several actions from my own service visits I've undertaken, they quite often, even 6 months later, I'll get an email from a member of staff saying, thank you, we've finally now got that resolved. So things do work through the process, but I will pass over to the others just to comment. Melanie?
Yes, the report that we write up that Joe referred to that captures key kind of factors and any actions that arose that we committed to within the service visit, that gets shared with the service visit lead as well, the service lead. So they get to see exactly what the non-exec or the exec or the combined input of all the people who visited. They get to see that report. That's really important for 2 reasons. One, invariably we've taken up their time, they've had to show people round, we've learned some amazing stuff, and it's really important that we reflect that back, everything that we heard, the innovations that we saw, but also it is a commitment to say, we committed to doing these actions, we committed to follow up with these things, and those actions are now what is getting tracked through the governance and assurance platform that Joe referred to. But I would also say, as Julia, I think, mentioned, that personally, as a NED, if I've been on a service visit and we've suggested that we'll do something, or I've taken away an action, I will follow up with that. And sometimes, particularly one of the things I've done is gone back and seen the service 6 months later to see, and particularly if there's something dramatic has happened, like they've moved facilities or something, but I'll go back and do a follow-up visit because that's again a rich source of assurance for a non-exec.
Right, thank you. Joe, briefly to close us.
Yeah, and I think, Michael, just to add to that, I think also service visits are a two-way process. So it's not being done to a service is an integral part of it. So example, I did a whole stream of service visits into the children's services team, special school nursing, children's community nursing, occupational therapy, physiotherapy, community paediatrics. And what it allowed for was conversations between the lead teams. So it's not a top-down process. It is a very, very much a two-way process.
Thanks, Joe. And just to add in that sometimes we do have system colleagues who also come. So we've hosted both the Deputy Chair of the ICB and the Chair of the Quality Committee on 2 separate occasions to do exactly that, get some of our services together and understand us a little bit more, similar sort of thing. So that's really important. Great, thank you so much. I'm sure there'll be some reflections on that, and people can absolutely email in, contact us if there's anything else you think of related to that. Just finally, in the chat, there's been 2 or 3 really good suggestions, a few questions. I know Adam's asking about referral profile into the organisation. I'll let Dave have a look at that and just see if there's anything we could look at for the future for that. Thank you for that suggestion. And thanks, Sheila, for your update about some improvements made by Adult ADHD Service to their referral processes. So some really rich information in the chat, so do have a quick look at that. But can I just say thank you to everybody on the call. I don't believe there's any other business that we've been notified of. Next meeting, don't forget the AGM on the 15th of September at 5:30 via Teams. And the next formal governors meeting is Thursday, the 2nd of October at 3 o'clock through Teams. And we'll see other governor colleagues in 5 minutes' time on the private governor call, if that's okay. Great, thank you very much, everybody. Really productive, useful session, and see you all at the next session. Thank you very much.
Thanks very much. Thank you.
Bye. Bye.
Bye-bye.